38-year-old previously healthy man comes to office due to episodic fever, night sweats and weight loss. For several months, remember these symptoms: fever, night sweats and weight loss. And he immigrated from Kenya with his family at age 14, and he doesn't use tobacco, alcohol or illicit drugs. The patient worked as a driving instructor and volunteer at homeless shelter. Temperature 37-99 degree Fahrenheit. Physical examination is normal with the exception of cervical lymphadenopathy. Lymph node biopsy is performed and revealing the Reed-Sternberg cells, the large binucleated cells with prominent nuclei. What will be the likely diagnosis? The correct answer is Hodgkin lymphoma. So here is explanation. The clinical presentation of the systemic B symptoms including the fever, night sweats, weight loss along with the painless cervical lymphadenopathy in the young adult is classic for Hodgkin lymphoma. And histopathology characteristically shows the Reed-Sternberg cells, the large cells with abundant cytoplasm and owl eye binucleated appearance. There will be the owl eye appearance, that will be the binucleated appearance. Just like this, there will be the cells and having the binucleated appearance, the Reed-Sternberg cells that will be present in Hodgkin lymphoma. Then next one is 64-year-old man come to office due to lump in his neck, and he has long history of chewing tobacco. On examination, there is ulcerative lesion in the left floor of mouth, and there is firm, palpable, non-tender left submandibular mass. Biopsy of submandibular mass shows malignant squamous cell carcinoma. Which of the following is most likely route of spread from floor of mouth to submandibular mass? So from floor of mouth to submandibular mass, the most common route is lymphatic route, that is the lymphatic drainage into the submandibular lymph nodes, lymphatic drainage into the submandibular lymph nodes. So here you can see the carcinomas of anterior oral cavity including the floor of mouth and interior tongue metastasize primarily via lymphatic drainage to level 1 submandibular and submental lymph nodes. Squamous cell carcinoma of head and neck typically metastasize regionally via lymphatics before systemic spread. So before systemic spread, the most common route of spread is lymphatic route. For spread of infection or carcinoma like the metastasis, the most common route for metastasis is lymphatic route for the squamous cell carcinoma. The next question is 60-year-old man undergoes lymph node biopsy due to persistent cervical lymphadenopathy. Histologic examination reveals the population of small lymphoid cells arranged in a follicular pattern. The cells demonstrate overexpression of BCL2 gene due to 14 and 18 translocation. BCL2 gene. So the protein encoded by this gene normally inhibits which of the following processes? So the protein that is encoded by this gene, BCL2 gene, encoded protein by which of the mechanism, by inhibiting which of the processes? So it's the by inhibiting the cytochrome C release, by inhibiting cytochrome C release. Because the BCL2 gene have some role in apoptosis, and that it plays by inhibiting the cytochrome C. So here is explanation: overexpression of anti-apoptotic protein. So the BCL2 is anti-apoptotic protein. Overexpression of anti-apoptotic protein BCL2 prevents apoptosis by inhibiting the mitochondrial membrane permeability and blocking the release of cytochrome C from mitochondria into cytoplasm. This is characteristic of follicular lymphoma. So this is the characteristic of follicular lymphoma because the BCL2 gene inhibits BCL2 gene overexpressed by inhibiting the cytochrome C, prevents apoptosis. The next question, 55-year-old man comes to clinic for evaluation of persistent fatigue. He drinks 10 to 12 beer daily. Examination reveals jaundice and scleral icterus. Abdominal examination shows hepatomegaly with tenderness to palpation. On test, hemoglobin is low, 8.1, and reticulocyte 0.5, HB low, platelets 1,65,000, that is within normal range, leukocytes 4,800, indirect bilirubin and lactate dehydrogenase 440. Peripheral blood smear shows macrocytes and macrovalocytes. Which of the following is likely underlying cause of this patient laboratory finding? It is the ineffective hematopoiesis, because here you can see the low hemoglobin, and the explanation is here. The alcohol misuse combined with poor nutrition leads to folate deficiency, because the patient is taking alcohol 10 to 12 beers daily. So the chronic use of alcohol misuse lead to folate and vitamin B12 deficiency, and when there is folate and vitamin B12 deficiency, then there will be megaloblastic anemia, in which the megaloblast formation will be there, where MCV will be greater than 100, because normal MCV is 80 to 100, and if it is greater than 100, it will be present in megaloblastic anemia. This result in, if when there is megaloblastic anemia and there is deficiency of folate and vitamin B12, because folate and vitamin B12 are really important for DNA synthesis. So DNA synthesis will be impaired due to folate and vitamin B12 deficiency, leading to high intramedullary destruction of erythroid precursor cells, low reticulocyte count, and there is a low reticulocyte count 0.5%, elevated LDH 440, and indirect hyperbilirubinemia. So this will lead to impaired DNA synthesis. So impaired DNA synthesis, when there is no DNA synthesis, then it lead to impaired or ineffective hematopoiesis, like there will be no proper or normal hematopoiesis, the production of the blood cells. And the next is 63-year-old man comes to emergency department for chest pain, ST segment depression in inferior leads. He is diagnosed with STEMI. Anticoagulant option being considered include unfractionated heparin and enoxaparin, fondaparinux. Which of the following anticoagulants is most effective in inactivating thrombin, that is factor 2A. Okay, so correct answer is unfractionated heparin. The unfractionated heparin contains long polymer chain that binds both antithrombin and thrombin simultaneously, making it the most effective at inactivating thrombin. Low molecular weight and fondaparinux predominantly inhibit the factor 10A. So low molecular weight heparin and fondaparinux basically inhibit factor 10A. While the unfractionated heparin that binds the antithrombin and thrombin simultaneously. Okay, then next, the 45-year-old man presents with severe nasal discharge, headache, sore throat, and leukocytosis of 58,000 with immature myeloid precursors, metamyelocytes. The leukocyte alkaline phosphate lab score is low. Which of the following most likely diagnosis? Chronic myelogenous leukemia, that is CML. Chronic myelogenous leukemia, because here you can see the leukocytosis of 58,000, that is much raised, because normally is 4K to 11K, and here it is 58K. and with immature myeloid precursors. So you can see the myelocytes, metamyelocytes band forms. So these all this indicate the myelogenous, and also the lab score is low. So here is the explanation, you can see, which is written here. Marked leukocytosis with elevated granulocytic precursor is characteristic of chronic myelogenous leukemia or leukemia reaction. Low lab score differentiates CML from leukemia reaction, which has high lab score. So high lab score in leukemia. Here you can see 34-year-old industrial worker experiences rapid onset shortness of breath, dizziness, palpitation, and flushed skin after accidental exposure to chemical fumes like cyanide, and he is immediately treated with intravenous hydroxycobalamin. This medication is most likely to improve this patient's condition by which of the following mechanism, because here the patient is exposed to chemical fumes, so he will experience cyanide toxicity, and he is treated with IV hydroxycobalamin. Because what is the mechanism? Actually, the mechanism is preventing the cyanide binding to the ferric ions, preventing the cyanide toxicity to ferric ions. Because in the fumes there is cyanide, and in the blood there is hemoglobin that has the protoporphyrin ring and having the iron in the center, that is ferric or ferrous form. So that's why the IV hydroxycobalamin prevents the exposure of prevent the binding of cyanide to the ferric ions. So here you can see the explanation. Hydroxycobalamin directly binds intracellular cyanide ions to form non-toxic cyanocobalamin. Vitamin B12 preventing cyanide from binding to ferric ions in cytochrome C oxidase in mitochondria. So hydroxycobalamin that was given through IV directly bind intracellular cyanide ions and form these non-toxic cyanocobalamin. So the next question is 62-year-old man with type 2 diabetes and nephropathy presents with fatigue. Lab results show hemoglobin 9.4, MCV 90, that is within normal range, but hemoglobin is low. Reticulocytes 0.3%, and serum creatinine 3.2, ferritin 350, transferrin saturation 30%. After appropriate treatment with the erythropoietin agent is initiated for his anemia, which of the following changes is most likely to occur in this patient's erythroid cells? So there will be the increase in the progenitor cell differentiation due to correction of the anemia. There will be the increase in progenitor cell differentiation. So here is the explanation. Exogenous erythropoietin stimulates the erythroid progenitor cell in the bone marrow. In the bone marrow there are erythroid progenitor cells, so exogenous erythropoietin will stimulate the erythroid progenitor cells in the bone marrow and promoting their survival, their proliferation and differentiation into the mature red blood cells. So next question is 50-year-old man with severe chronic alcohol use is admitted with bleeding tendencies. Initial labs show prothrombin time 26 and partial thermoplastin time 38 seconds. He is given intramuscular IM vitamin K. 2 days later laboratory tests are repeated and remain unchanged. Which are the following most likely cause of the abnormal laboratory finding in this patient? So the patient is actually deficient in factor 7. So here is the explanation. The patient has severe liver cirrhosis secondary to chronic alcohol abuse. So patient is chronic alcohol abuser, that is taking alcohol. So there is chronic alcohol abuse that is leading to liver cirrhosis, and due to liver cirrhosis there is the abnormal function of liver that leads to impact the clotting factor synthesis in the liver, because clotting factors are synthesized in the liver. If there is alcohol intake excessive, that lead to cirrhosis, and liver is not functioning properly, so not creating the clotting factors. And so factor 7 has the shortest half-life of all the clotting factors, that is 6 hours. The factor 7 have the shortest half-life of all the factors, that is approximately 6 hours. So prolonged prothrombin time unresponsive to vitamin K administration indicate the severe end stage liver synthesis dysfunction. So if despite giving the vitamin K intramuscularly there is no response, then it means that there is the end stage liver synthesis dysfunction, and that's why the patient is having prolonged prothrombin time. So next question is, cancer cells from 23-year-old male with testicular cancer demonstrates high sensitivity to etoposide. Etoposide killed cancer cells show a high number of double-stranded DNA fractures. These fractures are due to dysfunction of which of the following? That is the topoisomerase 2. Okay, so here is the explanation. Etoposide and teniposide inhibit the topoisomerase 2, causing the transient double-stranded DNA breaks that can't be religated, resulting in accumulation of double-stranded DNA breaks and cell death. So the etoposide and teniposide both inhibits the topoisomerase 2. So next question is, 48-year-old woman with HER2 positive invasive ductal breast carcinoma receives treatment with systemic chemotherapy and trastuzumab, a monoclonal antibody that binds the extracellular domain of HER2. Which of the following host factors are primarily responsible for mediating the response to monoclonal antibody therapy? So natural killer cells and the granzymes are responsible for mediating the response. So here you can see the explanation. Trastuzumab triggers the antibody-dependent cell-mediated cytotoxicity. CD16 receptors on natural killer cells recognize the Fc region of bound Ig antibodies, causing the natural killer cells to release granzymes and perforin to induce apoptosis of target cancer cells. So you need to remember the natural killer cells and granzymes are involved in this response to the monoclonal antibody. Because question was, which of the following host factors are primarily responsible for mediating the response to monoclonal antibodies? So therapy. So if monoclonal antibody therapy was given, there will be the response generated by natural killer cells and granzymes. Next question is, 54-year-old man presents with 2 months of fatigue, abdominal fullness and massive splenomegaly crossing the midline. Peripheral blood count shows the pancytopenia. All cell lines are low. Bone marrow aspiration yields the dry tap. So when there is the dry tap, there is fibrosis inside the bone marrow. There will be the fibrosis. Dry tap means there is no cells on the tap from the bone marrow, so there will be fibrosis in bone marrow. Which of the following findings is most likely present in this patient? So in this patient there will be the lymphocytes with cytoplasmic projection, because patient is actually having hairy cell leukemia, and in hairy cell leukemia there will be dry tap in hairy cell leukemia. Okay, and the patient will present with lymphocytes and there will be the cytoplasmic projections. There will be lymphocyte with cytoplasmic projections. So the clinical triad of massive splenomegaly, pancytopenia, dry bone marrow tap and lymphocytes with hair-like cytoplasmic projection. So remember the cytoplasmic projection with hair-like cytoplasmic projections. Hair-like cytoplasmic projections will be there. That is diagnostic of hairy cell leukemia. And in hairy cell leukemia, you need to remember this triad: splenomegaly, enlarged spleen, pancytopenia, that is the low, all the cell lines are lowered, and dry bone marrow tap. Okay, and next one is 62-year-old man with acute pyelonephritis treated with ceftriaxone. Day later, hemoglobin dropped from 12.3 to 8.4, and total bilirubin increased to 2.4. Which of the following is most likely cause of this patient's anemia? So it is the antibody mediated erythrocyte injury, because penicillin and cephalosporin like the ceftriaxone can induce drug-induced immune hemolytic anemia via heptin mechanism or autoantibody formation. Positive direct home test will be there. So remember that penicillin and cephalosporins can induce the drug-induced hemolytic anemia. Drug-induced hemolytic anemia will be there. Drug-induced immune hemolytic anemia, because you can see that total bilirubin is raised. That is actually raised bilirubin in hemolytic anemia, and also you can see the anemia, that is 12.3, hemoglobin drops to 8.4, and the patient is taking the ceftriaxone, that is cephalosporin. So remember the penicillin and cephalosporins here. Okay, so next question is 61-year-old man presents with right leg swelling after a long flight from Japan, and in duplex ultrasonography confirms deep venous thrombosis, DVT, and histotia rivaroxaban. And rivaroxaban inhibits which of the following factors? So it is the 10A. Apixaban and rivaroxaban inhibit factor 10A. Apixaban and rivaroxaban. Inhibits factor 10A. Okay, so rivaroxaban and apixaban are direct oral factor 10A inhibitors, oral factors 10A inhibitor, and contain XA like the rivaroxaban and apixaban in the name you can see. Then the next question is 56-year-old man with non-Hodgkin lymphoma receives chemotherapy including vincristine. So remember that vincristine, what is the side effect? The side effect or adverse side effect of vincristine is tingling and numbness of the fingers, finger tingling and numbness. So vincristine inhibits microtubule polymerization, mitotic spindle inhibitor, leading to peripheral neuropathy, distal symmetrical paresthesias, numbness, tingling, weakness. So it also inhibits the mitotic spindle, microtubule polymerization. Microtubule polymerization is inhibited by vincristine. Microtubule polymerization is inhibited as well and results in paresthesia, numbness, tingling, weakness. Mitotic spindle inhibitor, vincristine. Spindle inhibitor. Remember the drug name, that is vincristine. These are the adverse effects actually. Okay, 6-year-old boy presents with nosebleed, fatigue, generalized lymphadenopathy, and hepatosplenomegaly. Flow cytometry demonstrates cells positive for TDT, CD10, CD19, and myeloperoxidase is negative. Which of the following most likely diagnosis? It is B, lymphoblastic leukemia. So B ALL is the most common childhood leukemia. It presents with TDT positive immature lymphoblast marker and B cell markers CD10 and CD19. So you need to remember these CD19 and CD10 B cell markers. 19 and 10 B cell markers are these CD10 written, and CD19, and this is the B lymphoblastic leukemia. Acute lymphoblastic leukemia is the most common childhood leukemia, and you can see here the age as well, 6 years, with the nosebleed, fatigue, and lymphadenopathy. So next question is 12-year-old boy with acute lymphoblastic leukemia received maintenance therapy with 6 mercaptopurine. Which are the following enzymes inactivates this drug? So it is xanthine oxidase that inactivate the 6 mercaptopurine. 6 mercaptopurine is inactivated by xanthine oxidase, and TPMT co-administration with allopurinol, that is xanthine oxidase inhibitor, dramatically increase the 6 mercaptopurine toxicity unless the dose is reduced. So here you can see that allopurinol is xanthine oxidase inhibitor, and here we discussed that the 6 mercaptopurine that is the maintenance therapy that is used in ALL. So this drug is inactivated by the xanthine oxidase, and if xanthine oxidase inhibitor is there, then 6 mercaptopurine will increase automatically and result in toxicity. So here the next question, 6-year-old girl with Down syndrome and high burden ALL initiates cytotoxic chemotherapy. She is at high risk for tumor lysis syndrome, and which lab pattern potassium, uric acid, phosphorus, LDH is expected during the tumor lysis syndrome. So in the tumor lysis syndrome there will be the increase of all these: increase potassium, increase phosphorus, increase LDH, increase potassium, increase phosphorus, and increase LDH, increase uric acid will be there in tumor lysis syndrome. Massive lysis of malignant cells release intracellular ions into circulation, causing hyperkalemia, hyperuricemia, hyperphosphatemia, and which lead to hypercalcemia and elevated LDH. So all these potassium, phosphorus, LDH, uric acid will be increased except the calcium, that will be the hypocalcemia. Then the next question, 8-year-old boy receives an autologous bone marrow transplant using stem cells from his own peripheral blood. Pre-transplant evaluation shows history of past Epstein-Barr virus infection. This patient is at greatest risk for which of the following post-transplantation? So there will be the reactivation of Epstein-Barr virus. In autologous transplantation, host tissue rejection doesn't occur because donor and recipient are identical in autologous transplantation. However, severe post-transplant immunosuppression increases risk of latent viral reactivation. So the immunosuppression because of that transplantation, because immunosuppressors are given initially, so immunosuppression results in activation of the cytomegalovirus or Epstein-Barr virus, so deactivation of the viral infection. Then next question, 65-year-old man presents with worsening fatigue. Physical exam reveals late systolic ejection murmur at the right upper sternal border radiating to neck, aortic stenosis, and so in the aortic stenosis this will be the murmur that is present at right upper sternal border radiating to neck, and hemoglobin is 9, MCV is 93, peripheral blood smear shows schistocytes, fragmented red blood cell schistocytes will be there. Hemoglobin low, MCV normal. Which mechanism best explains the observed erythrocyte findings? So it is the mechanical erythrocyte injury. Calcific aortic stenosis causes shearing forces that fragment the red blood cells as they pass through the narrowed calcified valve orifice, leading to microangiopathic hemolytic anemia and schistocytes. So this is due to the aortic stenosis that is leading to microangiopathic hemolytic anemia, because the blood and the red blood cells are passing through the narrowed vessels, so it is microangiopathic hemolytic anemia, and there will be the schistocytes formation. The next question is, 16-year-old boy presents with fever, sore throat, generalized lymphadenopathy. Fever, sore throat, generalized lymphadenopathy, and splenomegaly. Peripheral blood smear shows reactive lymphocytes. Heterophile antibody test is positive, that is monospot test is positive. The agent causing this patient disease is most strongly associated with which of the malignancies? So it will be associated with mucosa associated lymphoid tissue lymphoma, that is malt lymphoma, and nasopharyngeal carcinoma and Burkitt lymphoma. Okay, so the agent that is causing the Epstein-Barr virus is most likely associated with mucosa associated lymphoid tissue lymphoma, nasopharyngeal carcinoma, and Burkitt lymphoma. So here is the explanation. The Epstein-Barr virus causes infectious mononucleosis. Epstein-Barr virus causes infectious mononucleosis and is oncogenic, strongly associated with nasopharyngeal carcinoma, Burkitt lymphoma, Hodgkin lymphoma. So next question is 50-year-old woman with SLE and fever develops acute bleeding from intravenous sites. Lab finding shows hemoglobin 9, platelet 68,000, PT 23, APTT 60 seconds, fibrinogen 100, which is low, and which are the following most likely cause of this patient hematologic abnormality? So it is the consumptive coagulopathy. So here is the explanation. Disseminated intravascular coagulation, DIC, is consumptive coagulopathy characterized by thrombocytopenia, low thrombocytes, and prolonged PT, APTT, low fibrinogen, and elevated fibrin degradation. So there will be the low platelets 68,000, thrombocytopenia, prolonged PT 23 seconds, and APTT, and low fibrinogen that you can see here is 100, and elevated degradation. So it is DIC. So symptom you can see, because the woman is having SLE and fever and develop the acute bleeding from the intravenous sites. Okay, 30-year-old woman presents with hepatic venous thrombosis, hemolytic anemia, leukopenia, and thrombocytopenia. Flow cytometry reveals deficiency of CD55 and CD59 proteins on cell surfaces. Which are the following most likely cause of this patient's anemia? So it is the complement activation. Okay, so you can see here the explanation. The paroxysmal nocturnal hemoglobinuria, PNH, is caused by somatic mutation in PIGA gene, leading to loss of GPI anchored protein CD55, CD59. This renders blood cells vulnerable to complement mediated intravascular hemolysis. So here you can see that this woman presenting with the hepatic vein thrombosis and hemolytic anemia, there is leukopenia, there is thrombocytopenia. So all the cell lines are low, and flow cytometry reveals the CD55, CD59 proteins. So the question was that which are the following most likely cause of this patient anemia? So it is the complement activation. It is the complement activation. Okay, so next question is researchers studying the CLL want to identify patient with trisomy 12 in lymphoid tissue. Which of the following laboratory techniques would be most useful? So the most useful technique in this case will be fluorescence in situ hybridization, that is actually fish fluorescence in situ hybridization. Okay, the fish use the fluorescent DNA probe to visualize specific chromosome abnormalities like depletion, duplications, deletions, duplications, and translocations, trisomies like trisomy 12 directly in cell nuclei. And next question is 22-year-old woman presents with severe abdominal pain, constipation, peripheral neuropathy, dark urine after starting low caloric diet, acute intermittent porphyria. She is treated with IV heme administration, which rapidly resolves her symptom. The improvement in symptoms is due to low down regulation of which enzyme? So it is the down regulation of amino-levulinic acid synthase. So here is the explanation. Exogenous heme inhibits the rate limiting enzyme ALA synthase. Via negative feedback, halting the accumulation of toxic porphyria precursor ALA and BPG. So there is inhibition of ALA synthase. Next question, 63-year-old man in hemorrhagic shock due to massive peptic ulcer bleeding requires rapid fluid resuscitation via intravenous catheter. According to this law, which modification provides the greatest increase in flow rate? So doubling the diameter of intravenous catheter. Doubling the diameter. Double the diameter of intravenous catheter. So here is the law that states flow is equal to, and flow is proportional to radius. Flow is proportional to radius raised to power 4th power. Doubling catheter diameter increase flow by factor 16. The next question, 55-year-old obese man with the BMI 45 with hypertension, progressive fatigue, and lab shows low hemoglobin 8.6 and MCV with the normal range 84, reticular size 0.2, blood urea nitrogen 14, creatinine 0.8, and stool occult blood test. Stool occult blood is negative. And which are the following most likely cause of the anemia? It is anemia of chronic inflammation. The severe obesity produced state of chronic low-grade systemic inflammation with elevated hepcidin levels leading to iron sequestration in macrophages, and normocytic anemia of chronic disease or inflammation will be there. 72-year-old man with severe aortic stenosis presents with gastrointestinal bleeding from chronic angiodysplasia. Which of the following mechanism causes this bleeding condition? So it is acquired von Willebrand factor deficiency, that is the factor 8A, von Willebrand factor. So here is the explanation: high shear stress across calcified aortic valve, uncoils, high molecular weight, von Willebrand factor, multimer exposing them to cleavage by ADAMTS13 and causing acquired von Willebrand syndrome, and bleeding from angiodysplastic syndrome, Heidi syndrome, angiodysplasias. Okay, so next question is 24-year-old man. 24-year-old man experiences episodic hemolysis with the jaundice, dark urine after starting sulfur drugs, and peripheral smear shows bite cells and Heinz body. Bite cells and Heinz bodies are usually we see in G6PD deficiency. So deficiency of which of the following enzyme causes this condition? It is G6PD deficiency, glucose 6-phosphate dehydrogenase, glutathione reductase pathway. So here is the explanation: and glucose 6-phosphate dehydrogenase deficiency impairs NADP generation and leading to depletion of reduced glutathione. Exposure to oxidative stressors cause hemoglobin denaturation and splenic bite cell creation. So there will be the denaturation of hemoglobin that will be visible as Heinz bodies, and splenic bite cell creation will be there because there will be the eating of the cell from that area that contains the Heinz body, so there will be formation of bite cells. So next question is 9-year-old boy with beta thalassemia major receiving chronic transfusion develop iron overload. Biopsy of liver Kupffer cells show coarse brown cytoplasmic granules, so the hemosiderosis will be developed. These granules are composed of which of the following? The hemosiderin. The chronic blood transfusion in the patient with beta thalassemia lead to hemochromatosis and excess iron accumulation as golden brown granules of hemosiderin in macrophages that are the liver macrophages, Kupffer cells. There will be the accumulation of the iron that would result in hemosiderosis. Okay, 25-year-old woman present with fatigue, pallor, severe pancytopenia, hemoglobin low, WBC is low, platelets low, all cell lines are low, reticulocytes 0.1%, splenomegaly, peripheral smear shows normocytic normochromic blood cells. Bone marrow biopsy in this patient with aplastic anemia would show hypocellular marrow filled with fat and stroma because the cells are low, so there will be hypocellular marrow, and if there are no cells then there will be the fat and there will be stroma. So here is the explanation. Aplastic anemia is characterized by bone marrow failure presenting with pancytopenia and hypocellular empty bone marrow, largely replaced by fat cells and stroma. Next question: 42-year-old man presents with fever, petechiae, and acute DIC, low fibrinogen. Bone marrow aspirate shows the abnormal promyelocytes with abundant xerophilic granules and ORR. So they are the ORRs and xerophilic granules. So chromosomal analysis of these cells is most likely to show which translocation. It will be the T15 and 17. So it is acute promyelocytic leukemia APL. AML-M3 subtype is driven by translocation 15-17 fusing PML and RARA genes. It presents with DICRR responsive to ATRA. 15-17 APL, that is acute promyelocytic leukemia. Okay, so next question is 5-year-old boy with homozygous sickle cell disease. Homozygous sickle cell disease, 5-year-old boy treated with hydroxyurea to reduce the vaso-occlusive crisis, because vaso-occlusive crisis occurs in sickle cell anemia, in sickle cell disease. So the boy is treated with hydroxyurea. Then question is that hemoglobin electrophoresis is expected to show elevated level of which hemoglobin. So on hemoglobin electrophoresis, there will be the elevated levels of HbS and HbF, the fetal hemoglobin and HbS, that is linked to the sickle cell. So here is the explanation. Hydroxyurea increases production of fetal hemoglobin, which dilutes the HbS and prevents polymerization or sickling. Patient with HbSS lack normal adult hemoglobin, so there will be lacking or deficiency of HbA, but there will be more HbF and HbS. More HbF and HbS, elevated levels. Okay, so next question is 70-year-old man with CLL receives venetoclax, an agent that directly binds and inhibits BCL2 protein. Which are the following most likely effect of therapy on cancer cells? So greater susceptibility to apoptosis and cytotoxic T cells, because we have discussed previously that BCL2 gene and the BCL2 protein basically inhibits, that is actually the anti-apoptotic. So the agent that is actually venetoclax that binds and inhibits the BCL2 gene. So when there is the inhibition of BCL2 gene, there will be inhibition of apoptosis. So the more apoptosis will be there, greater susceptibility to apoptosis and cytotoxic T cells. So here is the explanation. Venetoclax inhibits BCL2 and activating pro-apoptotic proteins backs are back and causing mitochondrial outer membrane permeability and induction of apoptosis in CLL. So it is the venetoclax that is actually promoting apoptosis, increase apoptosis by backs and back. Okay, so next question is electrophoresis shows abnormal hemoglobin variant migrating slower towards the anode than HbS due to glutamate being replaced with lysine. Glutamate replaced by lysine. And which type of mutation causes hemoglobin C disease? So it is the missense mutation that is causing hemoglobin C disease, missense. So here is the explanation. Hemoglobin C disease is caused by missense mutation replacing glutamic acid with lysine at position 6 of beta globin chain. And here it is written that HbS replaces glutamic acid with valine. Here the glutamic acid is replacing with lysine in hemoglobin C. Next question is scientists isolate monomeric beta hemoglobin subunits. The oxygen dissociation curve of monomeric beta subunits resembles that of myoglobin. Which curve represents this oxygen dissociation curve? So the line A, here it is written because line A show the hyperbolic shift to left. Hyperbolic shift to left. Here is the explanation. Monomeric beta subunits lack cooperative binding Therefore, individual subunits exhibit hyperbolic curve shifted far to left, high oxygen affinity similar to myoglobin. So there will be the shift to left because of the high oxygen affinity. So next question is 17-year-old girl with heavy menstrual bleeding presents with normal platelet count. Platelet aggregation study shows failure of aggregation with the ristocetin, which is corrected by adding new normal plasma. And which factor is deficient in this patient? So it is the von Willebrand factor, because ristocetin induces von Willebrand binding to GP1B, and in von Willebrand disease ristocetin cofactor activity is impaired but normalized upon addition of normal plasma containing the von Willebrand factor, differentiating from the Bernard-Soulier syndrome. So this is ristocetin cofactor activity is impaired, so normal plasma will restore it because it is containing von Willebrand factor. So next question is 15-month-old boy presents with cyclic episodes of aphthous mouth ulcers and fever occurring every 21 to 28 days, and blood tests during episodes reveal absolute neutrophil count less than 200, that is cyclic neutropenia, and bone marrow examination during the trough phase would show an increase in which of the following cells? So there will be increase in the myeloid progenitor cells with nuclear fragmentation and arrest. Myeloid progenitor cell with nuclear fragmentation or arrest. So here is the explanation, that is cyclic neutropenia, like very low leukocytes, neutrophils, very low neutrophils, cyclic neutropenia less than 200, exhibits periodic maturation, arrest of myeloid precursors at the promyelocyte or myelocyte stage, leading to cyclic neutropenia and recurrent mucosal infection, because the neutrophils are so low that there is arrest of myeloid precursors and at the promyelocyte stage, and that leads to more infections and cyclic neutropenia. So next question is 58-year-old man receiving bevacizumab anti-VEGF monoclonal antibody for glioblastoma experiences dehiscence after surgery. Wound dehiscence after surgery, and which of the following mechanisms explain the impairment in wound healing? So correct answer is depletion of endothelial growth factor for angiogenesis. Here is the explanation, bevacizumab binds and neutralizes VEGF, inhibiting angiogenesis required for granulation, tissue formation and wound healing, and leading to wound dehiscence and hemorrhage. It is anti-VEGF monoclonal antibody, so it neutralizes VEGF, and when VEGF, that is vascular endothelial growth factor, that is neutralized and that inhibits the angiogenesis, there will be inhibition of angiogenesis, so there will be the impairment of wound healing, lead to wound dehiscence. So the last question is 68-year-old man with atrial fibrillation is initiated on warfarin therapy. Which are the following the best laboratory tests to monitor the anticoagulant effect of warfarin? So it is the prothrombin time or INR. So here is the explanation, warfarin inhibits vitamin K epoxide reductase. Warfarin inhibits epoxide reductase, vitamin K epoxide reductase, affecting extrinsic pathway, factor 7 first, that having the shortest half-life. Prothrombin time INR monitors the extrinsic coagulation pathway and is used to monitor warfarin, because we remember that there was written prothrombin time and activated partial thromboplastin time. Remember the prothrombin time, the playing tennis, so you know that tennis is tennis is played outside, so it is extrinsic, and while APTT, that is playing table tennis, and you know that table tennis is indoor game, so it is intrinsic pathway control detector, intrinsic pathway through the APTT and extrinsic pathway detector is through PT. So here it is explain the same thing, the extrinsic coagulation pathway is detected through PT, and that's